Hey everybody, hope you're doing well. It's been a little while since I've done one of these, so I'm excited to be back here. Just turning on my light so I don't look so pale. I'm going to be going live with Ruchi Cohen, and we're going to be talking about midwives. So let me just invite her. Let's give it a second. All right. Ruchi Cohen. Okay, I sent the request, so let's see if this works. You know what? I'm turning this off. That's okay. Okay, let's try this again.
Hey, is it working?
Yay!
We're here.
Good job.
Okay, awesome.
I see you have a fan on here. And not your
I
number
do?
one fan, your husband's on here.
Oh, okay. Well, yeah.
I love that. My husband doesn't even have Instagram, and I think if he did, joining a live about when midwives would be like
He's my emotional support. I
list.
just listened to a podcast today that he did, so I guess we paid forward in both terms.
It's really
so.
nice. I'm going to tell him that your husband was on here to maybe encourage him to join the next one.
Sure.
Okay, so we are going to be talking all about midwives. We can't say long.
Mm-hmm.
Okay. We're going to be talking all about midwives. So basically, Ruchi, I know this is a little bit newer for this format's a little bit newer for you, but basically we're on here and people can like comment and ask questions.
Sure.
And then it'll get saved at the end. So I'll post it to my feed, and obviously you're welcome to share it as well.
Mm-hmm.
Sounds good?
Yeah. Sounds great.
Okay, perfect. Okay, so I'll introduce, I guess, myself for 2 seconds, and then I'm going to start asking you my questions, and you'll have a chance to introduce yourself. So for anyone who's joining from Ruchi's side, hi, I'm Lauren Seidman. I'm a Lamaze certified childbirth educator. I help expectant parents prepare and gain confidence for their birth and new parenthood. And I teach classes and provide content on my Instagram page and lives like this with people that are experts in their area. So Ruchi and I connected. I mean, we know each other from like a while ago from the city.
For sure.
And now we're neighbors in the 5 towns. So that's really funny that we're on the same route geographically. So
who moved here first? Actually, I don't even know.
You did.
Was it us?
For sure. Yeah, we're new. We moved here like a year ago.
Okay, got it.
So I would love for you to tell us a little bit about yourself and why you decided to become a midwife, and a little bit about what that path was like.
Okay, thanks for having me. So like I said, my name is Ruchi Cohen. I am a certified nurse midwife, and I'm originally from Vienna, Austria, fun fact. And I work currently in 2 settings, actually. I work in a private practice in Queens where we do deliveries on Long Island at South Nassau Hospital. And recently I've also become more involved with community birth, specifically home birth. And I do, consults, visits, and also home births. So I'm doing a little bit of both. My path to midwifery is long and winding. Started with the birth of my oldest son 16 years ago. I think that most birth workers, not everybody, but a lot of birth workers kind of become inspired or interested in birth through their own experiences. Yeah. So my son was born in Israel, actually, via C-section 16 years ago. He was breech. And while there are some providers who do vaginal breech, that wasn't quite on our agenda at the time. And before his birth already, I had become very interested in natural birth and, physiologic birth, things like that. And so it was, very disappointing to me that I wasn't able to have that experience the first time around. Yeah. I became pregnant soon after with my daughter. We were still living in Israel. And I was really, really motivated to have a VBAC or TOLAC or whatever you want to call it, vaginal birth after cesarean, which thankfully I was successful. And then we moved to America and had 2 little babies. My initial degree was actually in English and communications, but I was just we had just moved. I had 2 little babies. I wasn't really working at that point. But when I finally started thinking about what I wanted to do, I wasn't really interested at that point anymore and going back to that field, but I was really interested in being involved in birth. I started the process as a doula originally, and did that for a couple of years.
Yeah.
But then decided, I wanted to further my education. So when the opportunity presented itself for me to go back to school, I started prereqs for nursing school because I had like no science.
Right. It was totally different.
I didn't know they're like completely different.
Yeah.
I did prereqs. I did nursing school with 4 kids at that point. Okay.
Kudos to
and yeah, I graduated, and I was on the way. I wasn't sure about becoming a midwife. I definitely knew I wanted to be working, labor and delivery, working with women. I started working as a nurse in pediatric ICU, actually, because I wasn't able to get a job in labor and delivery. And I actually love that too. I love working with families. And at that point, I, after about 2 years, transitioned to labor and delivery and started midwifery school while I was working as a labor and delivery nurse. And for 3 years, got my master's. So long story, but basically it was the process.
Right. But I just think it's important to highlight like that process, even though it probably feels long to talk about it, because I think sometimes people, even when they hear the word midwife, and by the way, like I'm in this and I know what a midwife is, but even when I hear it, there's something like, so I think deeply ingrained within people that when they hear midwife, they think it's literally just like a woman that shows up to your house when you're having a baby.
Right. And then you just like took a course for a weekend, like for like 24 hours, a quick weekend course, like, Sunday, Monday, and then like go off and deliver babies.
Yeah, I think people don't really, and that's why we're having this conversation, because I think most people don't appreciate that long training and like you were in nursing school and you were working in labor and delivery, and then you went to midwifery school, and that was another 3 years, and it's a lot of schooling and obviously a lot of hands-on.
For sure. Yeah, definitely
learning. Yeah. So, okay, really appreciate you sharing all of that. So when it comes to care providers that people can choose for their pregnancy and their birth, there are really 2 options, right? Midwives and OBs. The vast majority of people in the US, at least, go with an OB. And I think that's really like the default for a lot of people. And I think a lot of that is because, there are probably lots of reasons, but one of them I think is just lack of information, maybe lack of education, lack of access. But before we get into all of that, can you just clarify, like, what is the difference between choosing an OB, what is the obstetrical model of care, so to speak, and a midwife? Like, how is that going to differ based on who you choose?
Right. So yeah, there are kind of 2 models of care when it comes to childbirth, or the way we usually see it. And one is considered the obstetrical medical model of care, and the other one is the midwifery model of care. And that is basically this idea that pregnancy and childbirth are natural processes, versus where the medical model might see it more like as a disease or as a problem that needs to be supervised. We think of it more of a process that occurs naturally. Sometimes, obviously, problems do arise, and sometimes we do have to intervene in some way, but the de facto default position is that what's happening is normal. Your body's capable of carrying a pregnancy, your body's capable of having this baby, and we start from that. And we believe in a more holistic process that takes into account, obviously, your medical history, the physical aspects, but also much more also like the social aspects, psychological aspects. How are you feeling? Who's your support? When we have your visits, it's not just about like, okay, this is the baby's heart rate and this is your blood pressure and these are the medications you should be taking, but also like, how are you doing? How are you feeling? What's bothering you? What's on your mind? Taking into account much more the whole picture. And just reading here about, I had printed this out, is just saying that the model has shown to reduce the incidence of birth injury, trauma, and cesarean section.
Yeah, totally. There are really great statistics when it comes to midwifery care in terms of lower intervention. Which then can lower things like the incidence of C-section. But it sounds like also it's just respecting the process more and thinking of it more as like a life event versus a medical condition. Right,
a condition that needs to be like managed and supervised and like at all points. And another thing that's important is also this idea of like informed decision making and like decision making together with the client, meaning not saying like this is what's going to happen, but this is what your options are, this is what we can do,
Right.
you know, what are your things. Obviously we always educate and we want to provide the evidence, but we're not generally dictating care.
And it's, I guess the assumption would then be, so it's more typical for someone like for the obstetric model of care, where it's more of like the care provider, the OB in this case, directing the care versus involving the patient more in their care. Is that?
Exactly. Yeah. It's more about having a conversation because, you know, as a labor and delivery nurse and even as a midwife, I've been there, I've been in the room when the doctor's just like, oh, don't worry about that.
Mm-hmm.
Just let me do what I need to do. And you just, you know, everything will be fine. Don't worry, you know, or just saying, oh, we're doing X, Y, and Z, not without an explanation.
Yeah.
And just like walking, you know, being like, come back in 4 weeks, or we're doing the sonogram next week, you know, without explaining like, why are we doing the sonogram? What are, you know, even little things, it doesn't have to be big things.
Yeah. And do you think that that is like across the board, or is that more of like a personality thing? Is that a function of how much, you know, time the OB has? How does that really play out on like an individual level?
100% it's personality too, because there could be midwives that are much more medically focused and maybe work in practices also where they're seeing patients, you know, on a 10-minute increments, and that doesn't really give them the time. And there are plenty of wonderful like OBs who take the time to get to know the patients, who take the time to explain things, and you know, to really give that, you know, that process. But at the end of the day, it's the midwifery model of care encourages it more. So maybe like we talk about it in school more, and it's something like that we learn in school, whereas I feel like maybe in medical school, maybe that aspect is not emphasized as much, and it's more something that somebody has to develop on their own.
I understand. So that makes sense. That's a good differentiation. So if someone is if someone is deciding, let's say, whether they want to go the OB route or the midwife route, how do they how might you suggest they like find out their potential care provider's stance on birth? Let's say, do they see birth as a normal event, or is it more of a medical issue that needs to be solved? Do they
like what kind of
decision making? Like, how might someone find that out?
I think generally you can get a pretty good vibe, you know, just, you know, going to the office and just asking some questions and just seeing how the office runs in terms of how a provider, you can say, you know, how many meetings will we, you know, how many visits will we have? How long are the visits? How accessible are they in terms of if things come up, you know, between sessions, and just asking questions. And it's not even about like, I know this is one of the myths for later about like people who are choosing an epidural versus not wanting an epidural, or, you know, things like that, but just about how does your provider feel about epidurals? How does your provider feel about going past your due date? Those are some good questions to ask. How does your provider feel about, you know, intermittent monitoring? Right, having a doula, because if your doctor says like, oh, I don't like doulas, or they just cause trouble or whatever, that can be a little bit of a red flag, because yes, sometimes doulas, you know, work outside of their scope and maybe get involved where they shouldn't, but overall doulas are amazing and they can be so vital for support. So if a doctor says, like, some doctors will say that, like, I won't work with a doula, like, you can't bring a doula, or I really don't want you to, that is a little bit of a red flag.
I would agree with that. I would definitely agree with that. Okay, that's a really good point. Okay, so let's just go back a little bit. So we talked about your training and your long road to becoming a midwife. I know that so you're a certified nurse midwife. I want to hear a little bit about you, and then I just want to clarify that there are different types of midwives. So you mentioned that you work in a practice. I know you work in a practice with other OBs, as well as outside of that practice, right, for home birth. So could you talk a little bit about what your experience has been like working in a practice with OBs, and then, you know, how the patients may benefit from that type of care model, and then also like what it's been like being home birth midwife?
Right. There definitely are different models of care, you know, even just working in an OB practice. And my patient population is very different. And I usually try to take my cues from them in terms of what they want. My time is a little bit more limited, you know, in an OB office. I don't have, you know, 45-minute sessions with people, which I did, but I always I always make that effort to still try to get to know my patients, ask them what they do, you know, are they working? Do they have other kids, their partner, things like that. Even if it's just 5 minutes, but just to check in and see how they're doing.
Sure.
And making that effort to explain things, you know, in the office and saying like, this is the next step. This is what we do. You can choose not to do it if you don't want to. Like an important thing, for example, is like, it's very standard in an OB office to check a patient's dilation after like 36, 37 weeks every week. And some patients love it because in their mind, they want to know this information. Even if I explain to them that it's not really significant because they could walk around that they could be, you know, completely closed and have a baby tomorrow and they could be 3 centimeters and still walk around for a week. But I offer it, but I always tell them that they can decline it because it's their body and it's not really necessary. Sometimes I offer them, if they're really getting anxious to get things going, to strip their membranes, meaning to do an exam and to actually try to, like, you know, it's a little bit more uncomfortable, but it's, again, a discussion of, like, you know, is this something you want versus...
How do people feel about that? Like, I had an experience recently where someone told me that, you know, she was, like, while she was in the hospital, like, she said that the nurse that you had, sounds like a great nurse to me, was, like, giving her options, and she was like, I don't know, like, can you just tell me what to do? And, like, I also get that. Like, sometimes I think people, especially if it's your first baby, not everyone, but I do have heard it enough where people are like, I just want someone to tell me what to do. Like, what are your thoughts?
I have some people who say that to me. They're just like, whatever you want to do is fine. Like, whatever test you want to order, I trust you. You're the provider. And I'm not out there to tell people what they need to do. I still will explain to them what I'm doing because it's just what I feel like is the right thing to do. And I follow the standard of care in my office. But I can understand that it can feel overwhelming. And I always encourage people to get more information, but I don't like to be pedantic about it. If you don't, some people, the medical model of care is amazing for them, and that's what they want. And they want to be able to say, I trust my doctor. I know what he's doing. He's been doing this for 20 years. This is my first baby. I just want him to tell me what to do, and I will do it. Mm-hmm. And I don't think there's necessarily anything wrong with that if that's what the patient chooses. Right. The issue becomes if somebody wants something different and they're not able to get that.
Right. It's more about, like, having the choice. I also think, like, even if someone, you know, is saying, like, I would just want someone to tell me what to do, let's say. But I do think on some level it's helpful to have that conversation so that you can feel like you really understand what's going on. Because I'm thinking about, okay, the next step, let's say, you know, some sort of intervention is recommended and you're like, yeah, just do it, whatever. But then you have some sort of, you know, it's going to impact you in some way. And then you don't understand, like, they say, okay.
And nobody told you, you know, that this could happen.
Right. So if you don't understand, like, what the impact of that could be, then you're going to feel, like, totally taken for a ride, you know?
Yeah.
Like, you were, like, out of control. So I think that, so what it sounds like is, like, the starting point for midwifery model is, we're going to discuss this. We're going to give you the options. At the end of the day, it's your choice. If you want my recommendation, I'll give you a recommendation. Whereas the medical model, the starting place is more of, you know, the OB is the expert in the room, and their take on it is likely how things are going to go, unless you say otherwise.
Right, unless you, like, actively, you know, make a statement or say that.
I hear that. Okay, I hear that.
There's a midwife on Instagram who talks about, her handle is like Dr. Midwife or something, which talks about the medical industrial complex, which is just like this, unfortunately, I mean, thankfully there's, you know, hundreds of thousands of babies being born, but what happens is it becomes like this assembly line on some level, this complex of, like, we have to move people through this process of having a baby. We have to get you in, we have to get you out. So things become very standardized, you know. Right. And I think the difference, I guess, in community birth or in home birth is that we really try to individualize things. And that means that we're taking a lot less clients on than, let's say, a standard OB or maybe even a standard midwife, you know, because we're really providing that kind of, like, it's almost like boutique care. Like, it's just, you know, you really have that time and that individuation.
So let's talk about your home birth practice. So how much time do you spend typically at a prenatal appointment with a patient or the client?
So I would say minimum 30 minutes up to, like, an hour for, like, a new patient, somebody new coming in, you know. And sometimes it's just, like, as long as it takes to to make sure that all their questions are answered. And again, I leave time for just schmoozing and getting to know them and just what's going on in their life.
Mm-hmm. And in terms of the care that you provide, how similar or different is that than what is in scope of practice for an OB?
So the care we can provide is very, very similar because we can order all the same tests. Like if somebody wants to do the, the prenatal testing, the sonograms and everything like that, we have the scope of practice to order all the testing, all the blood, do the blood work, prescribe medications. I think the difference is really that people who choose that are more naturally minded and they're often not interested in those things. So a lot of times I'm not ordering them because my patients don't want them, but I always offer them because it's always important to me not to make assumptions to say like, oh, you're having a home birth, so you don't want to do X, Y, and Z because obviously that's not of interest to you because I always want to offer it. So it goes like in the other direction, meaning like even though she'll probably decline it, I'm still going to offer it to her.
I hear. Okay. And when it comes to like things that come up during pregnancy or even like at the end of, at the end of a pregnancy, when things that might arise with someone seeing an OB, like induction or a C-section, like if someone's baby is breech, let's say, or they have placenta previa, like any other indication for a C-section. Okay, so then what? Like I know midwives can do all of the things pretty much that an OB can. They're basically, like you're saying, it's similar scope of practice, but a C-section I know is out. So what happens?
We can first assist, but that's a whole different story.
What did you say?
Midwives can first assist in surgeries if they get certified, which means they can be, usually there's two people doing the surgery, so they can be the secondary person.
So I just think that's a really important thing for people to hear.
So, I mean, not all midwives do it, but it's just like interesting because people are like, well, I need to have a C-section. My midwife's not going to be there. And it's not always the case, but you should find out because your midwife may actually be able to be there, either just physically in the room or she may actually be involved in scrubbing with the OB if that's something that she does, because many do, not all, but some do. So in terms of complications, so we're, like I said, we assume normal, but we're always on the lookout. So if anything comes up, we do check. And we have, a maternal fetal medicine specialist that we consult with if we feel like there's a need, and he'll do sonograms for us if we need, and he'll, give us his opinion always. Is this something that is concerning? Can we still move forward with a home birth, or are we thinking about, transferring? If we transfer care, so there are places other than New York, other countries, and even other states where the transfer from a home birth to a hospital is more smooth, where there's a specific protocol in place. New York is, unfortunately, New York City and New York is not really that place. So every midwife kind of has to figure out for themselves how they will.
So what do you do?
How do they handle that?
I think that is really at the crux of people's concern about midwife. I'm saying even with home birth, I know that I know the crux of this concern is really what do I do if there's an emergency? Or what do I do if there's a complication? I'm going to be honest, I would love to have a home birth. My husband is no way. We're having a home birth. Because what if, and people that choose to have a home birth, or even if they hire a midwife, their family is well, what if this? What if that? What if this? What if that? And I'm sure that part of that is the culture and the socialization that birth is, an emergency waiting to happen, which it's not, and I completely agree that it's not. But really, what happens in those situations so that people can understand, you're not going to be unsafe, you're going to be taken care of, but what do they do?
What are they doing? Okay. First of all, I want to differentiate. If you are getting care from a midwife who does deliveries in a hospital, there's a very safe and there's a very easy protocol in place because every hospital has an attending, a hospitalist who's there 24/7. They have to have that. So if there's an emergency, there will always be somebody physically present who can do a C-section. And sometimes like I said, I work with a practice. If there's an emergency, I have a backup to call, and I have the hospitalist there. So the hospitalist is physically there and my backup is 30 minutes away, right? So that's in a hospital setting. It's usually not an issue. Home birth is a whole different story, and it is a big step to say I'm going to have this baby at home. Yeah. But we also have to define emergencies. Most transfers for home births are non-emergent, meaning a lot of the time it's for exhaustion, meaning just a lot of times first-time moms, they've been in labor for 36, 48 hours, and they're just exhausted and they can't do it anymore. Things are not progressing. They're not feeling, and it's time to go get some rest, maybe get an epidural. And again, that's not a failed home birth. That's the process that you have to go through. And a lot of times when that happens, like I said, it's not emergent. You can choose the hospital that you want to go to, either the hospital that's closest to you, or if you have a relationship with an OB or somebody, that's where you go.
Yeah.
So we screen our clients very carefully. So we haven't, I mean, we're relatively new practice, under a year, but we have not transferred a patient yet.
Right. And when you say screen, what can you just elaborate on what you mean by that?
So in terms of candidates for home birth, so we would say like so things like, high blood pressure that needs medication, or diabetes that needs insulin, gestational diabetes that needs insulin, any more medical issues. If somebody's on, has an autoimmune disease, maybe. I mean, and you have to also, obviously, every situation has to be evaluated,
Yeah.
individually. If a patient's taking has hypothyroid, but it's well managed and they take Synthroid once a day, that's just probably fine.
Right.
You know what I'm saying? If someone has uncontrolled hypertension and their blood pressures are super high, that's probably not a great idea.
So meaning someone that would be considered a safe candidate for a home birth is someone that doesn't have any other medical risk factors that would put them at a higher chance of complications arising. Right. So you're already setting yourself up in a situation where, okay, you're low risk, and that's who's going to be a good candidate for a home birth. Otherwise, hospitals considered safer.
Correct. And there's also, we screen the baby, meaning we generally try to at least have an anatomy sonogram. So we know we have a healthy baby. If there's a family history of, let's say, cardiac issues, then we may recommend even a fetal echo, right? To make sure everything's okay. Because again, you're taking a lot of responsibility into your hands, and we take that very seriously.
For sure.
And I think people don't always realize that. They think that we're just kind of like airy-fairy, just showing up, and just like everything's cool, But we are medical professionals. We are supervising. We are listening to heart rate. We're watching you all the time. We're not just like chilling and
just like showing up with like tea and
with popcorn and
like ready to touch the baby,
right?
Not what it's like.
Exactly. But I'm not, I can't promise somebody that everything is going to go 100%.
Right. It is unpredictable.
Perfect. Because birth is unpredictable, and sometimes emergencies do happen. Most emergencies can be handled at home. Like if you have a hemorrhage, generally we can handle that at home. If you have a shoulder dystocia where the baby's shoulders get stuck, that can be handled at home. If you have a tear, we can suture that at home, assuming it's not, a third or fourth degree. A lot of things can be handled at home.
But
Some things
go ahead.
Cannot. Like if you have a cord prolapse, and the cord is out before the baby and the baby is nowhere near coming, that's something that could be very, it's probably not a good idea to happen. However, for example, we don't break someone's water, really almost ever, unless maybe the baby's crowning and we feel like we want to just help a little bit. But other than that, there's really very little room for breaking someone's water at home. So the chances of having somebody's water break while their baby's super high and the cord slip out is much smaller. It's not zero, but again, we're doing risk management.
Right.
I think what people need to understand also about birth is we believe that birth is a physiologic process, but we also know that emergencies can happen, and emergencies can happen in the hospital too. And in halacha, a woman who's having a birth is a chola, right? Which means that we can, be machal Shabbos for her, do whatever she needs when she's in labor, because there's a real need and there's also a real risk, right? 100%. But when people place it into hospital birth is 100% safe and this is not safe, that's when the issue comes up, because hospital birth has risks too, right? You walk into hospital, you now have a 30 to 40% risk of having a C-section, right? You have a risk of infection, you have the risk of getting medication maybe that's not meant for you. Hospitals are amazing, amazing places. I worked in a hospital for 5 years and we saved lots of lives, but we also sometimes cause problems that we then fix, and then we say, oh, Baruch Hashem, you were in the hospital and we saved your baby, but really we caused this whole cascade to begin with, Yeah. Not always, but sometimes. 100%. There's I don't like to speak in absolutes,
I know. I think it's a really good distinction, because I also find that there's this desire, and I think it's normal, human desire to want to control. You want to control, you want to have as little risk as possible. And I remember one of the things that was brought up during my certification training to become a childbirth educator was life is not risk-free. Anything you do involves risk. Yeah. And so what you're saying about hospital birth versus home birth is that each one has its own unique set of risks, and each
For
person
sure.
has to decide which set of risks they're comfortable with.
Right. And we can't make that call for you, right? You have to make the decision. What risks are you willing to take, and what, what benefits, what are the benefits to this? What are the risks and benefits? It's any decision in life. I feel like you have to weigh those things.
100%.
I was talking to somebody today, and I don't want to get into this about COVID vaccines and stuff. And
No.
It's not. But I'm saying same thing, risk benefit. What are the risks you're willing to take? What are the benefits?
Yeah.
It's everything in life. And like my husband makes fun of me that I became a midwife because I am such a control freak and I love to control everything as much as I can. And he's like, and you're in a job that's like very unpredictable. You can get called at any minute, and like, it doesn't make any sense for you. But it's really, I feel like childbirth is always the first lesson in parenting, which is you're not in charge. You're not in control.
Totally agree. Totally.
Yeah.
Totally. And I think it's very, very hard during pregnancy. Like I find like with my students, everyone has to like fill out a form before they take my class. Yeah. What are your, like, do you have any fears, anything you're concerned about?
Yeah.
And so much of it is like lack of control, or, the pain, the unpredictability, like so much of these things that are out of our control. And I really think that pregnancy and birth, like you're saying, is like the first time where we're really confronted with the fact of like, we are not in control. Like we're never in control.
Something is happening to our body that we can't.
Yeah.
We can't.
We never are, but we can create an illusion that we're in control. But
100%.
When you're pregnant and there's a baby, please God, growing inside of you, and you have absolutely, basically nothing to do with it. Like you're just going about your normal day, and your baby's
just like an incubator, right?
You're not in control, and then birth happens, and that's also out of your control. So I just think it's an important thing for people to remember. Like everything has risks, everything has its own set of risks, its own set of benefits, and each person individually has to decide what's right for them.
And I don't think home birth is right for everybody, but I think it should be an option for people.
For sure. It's just so not. It's so not for most people.
It's not mainstream.
And if it's on their radar, it's like on their radar because they're like, I would definitely not do that.
Right. And everybody's heard like a terrible story. Everyone wants to just tell you about their friends, cousins, terrible story,
And I think it's just like culturally, it's definitely, the norm that's not the norm in our country. In other countries, it is.
Right. And the thing is that, like, if you look back into the history of like midwifery and childbirth in America before 1920, I mean, we're going back 100 years, all babies were born at home. That was like all there was. There was only midwives. Then birth moved to the hospital, and it became like a luxury. It was seen as like a luxury to be able to go to the hospital when even the outcomes were worse. I mean, the way that, and this was not in America, this was in Europe, the way they discovered like sanitation and like hand washing techniques. I don't know if you ever heard the story about the medical students doing autopsies.
I don't know.
Basically, women were going to the hospital to have babies, and they were dying. This was 100 years ago, right? Or more, in droves. They were dying, and no one could figure out why they were all dying from sepsis, from infection, post-delivery in the hospital, right? So what they discovered was that the medical students used to go in the morning to do autopsies and learn about bodies and all that and how bodies work, and that's how they learned physiology. And then they would go in the afternoon to deliver babies. But nobody knew anything about like sterility and hand washing and all these things that we take for granted. And they would literally like give all these women like sepsis, right? Until they discovered that, oh wow, maybe we should wash our hands. Maybe we should wear sterile gloves. Maybe all these things. I'm saying like, so if you think about like the evolution of things,
For sure. I think it's important for people to like look into the history of how things came to be.
Right. At this point, about 12% of births are attended by midwives in the U.S., and about 1% of those are home births. So it's still very, very small.
So small. It's so small.
Yeah.
So if someone like is interested, let's say in the midwifery model of care, how can they go about finding a midwife? Like, where do they start? Oh, I will also can you actually, before we get into that, can you just elaborate a little bit on the different types of midwives? Because I know there's CNM, certified nurse midwife,
right,
and then there are others too, which may then influence the place of birth that people would be birthing in.
Right. Yeah. So there's actually three types, but try not to make it too complicated. The most common type is a certified nurse midwife, which is somebody who has a nursing degree first, a bachelor's, and then goes on to get a master's in midwifery.
And that person in the hospital and could do it at home too. Is that right?
Right.
Or birth center.
Correct. So they have the biggest scope of care, scope of practice, certified nurse midwives, because, like you said, they can do deliveries in the hospital, they can do deliveries in birth centers and at home, and they also have a whole GYN scope of practice, meaning we do pap smears, we do birth control, we do IUD placements, annual exams, breast exams, anything that you would need, really we can do as well, certified nurse midwives. There's also a certification that's more recent. It's called a licensed midwife. These are midwives that have a master's degree as well, but they have a bachelor's in a different field.
Okay.
And that's that exists in New York and a few states, but not all over. Most states still require you to be a nurse first. This one you can have a bachelor's in a different degree and a master's in nursing in midwifery, and your scope of care is pretty similar to a certified nurse midwife.
Okay. And you could do birth in the hospital, birth center at home. Okay.
Yes, the scope of practice. Then there's another certification called certified professional midwives. And these midwives sometimes also called lay midwives. And this is not a master's degree. It is a direct entry degree, and it is more of a certification. There's different paths to how to get this certification. And in different states, what's really confusing about America is that every state has like their own regulations about midwifery and who can practice and who can deliver. So certified professional midwives, they are only certified to do childbirth and pregnancy. They don't do GYN at all. And they can only attend births in birth centers or at home.
Okay.
And their training is, they have courses, and they also they do a lot of like hands-on, like they do what they call an apprenticeship, which is usually a year or two of following a midwife around, doing they have a very large amount of hours and births that they have to log in order to be certified.
Okay.
In New York State, CPMs cannot practice right now.
Got it. Okay.
In New Jersey, they can. So it's like you can drive over the George Washington Bridge and then you're fine. So it's very different. There's actually a push a little bit right now to legalize CPMs in New York. Mm-hmm. Because they feel like people should have more options.
Access. Yeah, more options for sure.
Yeah, but it's important to know that CPMs is not a master's degree, and also that they can only do births, like I said, in an out-of-hospital setting.
Right.
So either birth centers or at home.
Right. Okay. That is very helpful.
And they often can't prescribe as well. They can't prescribe medications.
They can't prescribe medications. So then I think that goes back to our other question. Like, then what?
Right.
Are you stuck? Like, do you have to switch to an OB? Like, do you have to switch to a different type of midwife? Like,
right. I'm not, honestly, I need to be more educated about CPMs. I don't know how it works, but I think, like I said, they work with very low risk populations. A lot of times they work with a lot of like homeopathy and alternative medications.
Got it.
Because to my knowledge, I don't think they can prescribe.
Got it. Okay.
Whereas we can't prescribe everything, even narcotics, which I don't like to prescribe, but I
can. Yeah. Okay. So CNM, CPM, and professional midwives, right?
And licensed midwives is the last one.
Okay. Yeah. Got it. Amazing. This is very helpful. So if someone wants to find a midwife, how can they go about doing that?
So ACNM, which is the official organization for midwives, American College of Nurse Midwives, they have a directory. I think it's like finding any other doctor. You have to like ask around. Like you can check your insurance plan and see who's available, and then get references like anything else. Like you wouldn't just like, hopefully if you were choosing an OB or if you were choosing a dermatologist, you wouldn't just like open the phone book and like choose someone, or look at your, you would try to get a recommendation. So it's kind of hard to, recommend specific things to do because every state and every area is very different in terms of the midwives that work there and that are available. Some states are better. Like California is a great state for midwifery. New York is like,
New York is okay.
Is okay, yeah.
So other than California, are there any other states where midwives are really like more the norm?
I think like on the West Coast, like California, also like Oregon, but like I don't know that there's a lot of people there, but like kind of like that West Coast kind of feel vibe,
Yeah.
A little bit more alternative kind of, yeah.
Got it. And
maybe
I feel like also if someone this is one of the questions I had, I feel like it's important to just bring up, like, if someone is in an area where there aren't a lot of midwives available, there aren't any midwives available, they really want one. So what sort of options would someone have in that situation? I guess they could travel, like you said.
Right, that's one thing. Decide how far they're willing to travel.
Right. Find an OB that maybe is more midwifery minded.
For sure. And there are, like, again, like there are amazing OBs out there who will honor your wishes and your preferences.
Yeah.
You just, again, I think that's when it comes down to really like doing your research and finding those friends who are similar in Hushkaffa to you in terms of what you're looking
Your birth
for and
Hashkafa.
asking around. Yeah, exactly.
Yeah,
And asking around and being like, who did you use? Where did you go to? What do you think? Because really
that's the best way to find it out.
that's it. Yeah.
Here.
Hmm.
Okay, this has been so helpful. So just to wrap up,
Yes.
the OBs typically are a medical model of care that sees birth as potentially an issue, as they're looking for the issues to be fixed. Whereas midwives
Right.
operate under the midwifery model of care, which treats birth as a normal, natural process and intervene when necessary, but typically looking at it as a physiological event. Would you say that that's like a good way to sum it up?
100%. The only thing I wanted to still touch on, and I think we talked about it a little bit, was just to say this differentiation between like a midwife and a doula.
Yes. Oh, yeah. Okay. So my
Yeah.
next question was, is there anything else you want to talk about? So let's go there.
Yeah. Yeah. So doulas are amazing. I was a doula a long time ago. And they're very, very important because sometimes the doula will be with the patient or the client way before the midwife or the doctor arrives. Like let's say if somebody wants to labor at home before they go to the hospital for a little bit.
Right.
And they're there for the emotional, physical support. They do massage, they help people breathe, they do all the really, really amazing things. At the end of the day, though, they're not a medical provider and they can't give medical advice and they can't, they can't like examine you, they can't deliver your baby. It's a certification and they work really, really hard and they work crazy hours and they do amazing things, but at the end of the day, they're not a medical provider. Again, a midwife is, like we said, a medical provider who has a full scope of practice, who can deliver your baby and, handle most emergencies. And so it's just, and a lot of times we work together and we work together very well. But it's just important when people say like, oh, you're a midwife. Oh, so you're a doula and you go and you hold people's hand. I just want to like make that differentiation that people understand,
Thank you for
what
bringing that
what
up.
we do.
Yeah,
Yeah.
it's very, very important. I think that there's this notion that anyone who's not an OB who works in birth is a doula. Like I also get that question, and I'm obviously
Right.
nowhere near a medical provider like you are. But
Right.
even when I'm like, oh, I'm a childbirth educator, like, oh, so you're a doula? Like, oh, you're a midwife? Oh, you're a doula? It's like, no. These are like all different people that can help
Right.
you in different ways, and like
Right.
it all fits together like a puzzle,
Right. Right. And the other thing also just about midwifery models of care is that if you look at, there are countries, for example, Israel or Sweden, Norway, that have like much higher rates of midwifery attended cares, and their results, like their, stats are much better actually than the US's stats in terms of like birth outcomes, mortality rates, and all those things. So we see that places where really the midwives are the ones in charge of doing the deliveries, we see the outcomes, in the data. America is like number like 43 or something in terms of maternal outcomes or something like ridiculous.
For anyone who's watching, who's listening to this now or after, the U.S. spends like one of the highest amounts of money on healthcare, and we have I think we have the worst maternal outcomes of the developed countries, or one of the worst outcomes.
100%. Yeah.
And it's embarrassing. And so
right. And that's
that alone should make people question what type of care they're getting.
Like, is this working for us?
And the answer is working. Like, are more interventions and more money being spent really working? Or should we maybe think about it differently?
In a different,
yeah,
exactly. Is this working for us? And also and that's why I think a lot of times people, when they go to hospital, they love the technology and the monitors and the beeping because they feel like very protected by that. Like, look at all these things that are watching me, that is monitoring me, that's supervising me, but it's not always the best thing for you and your baby.
How do you think someone could get comfortable with that level of, with a lower level of monitoring and intervention?
I think it's a process, and I think it's about, reading more about it, learning about it, really looking at the data, to see, what supports it. Because, for example, like the biggest, thing is, continuous fetal monitoring, which is when most people when they go to the hospital have a baby, as soon as they walk in, they stick a monitor on you and they don't take it off till you have your baby. It's continuous fetal monitoring. And since that has been instituted in the 70s, our C-section rate has skyrocketed, and our outcomes are not necessarily better. right? And the research has shown that intermittent monitoring, which is listening to the baby at certain specific intervals, it has the same, if not better, outcomes than the continuous monitoring.
And I also want to point out that ACOG, like the American Congress of Obstetrics and Gynecology, which oversees OB, actually recommends intermittent monitoring for low risk people. So
exactly. For people who are not being induced, right? I mean, if you have Pitocin, if you have an epidural, you know, any medication, once you start doing that, you need the continuous monitoring. But if you're planning to have an unmedicated birth, then you should definitely ask your provider if you would be a candidate for the intermittent monitoring.
Yeah.
And you'll just be more comfortable in labor too, because you're not like bed.
Right. But this is like sort of is what we were talking about at the beginning. Like what you're saying is that's standard. Like intermittent monitoring, something that improves outcomes, is standard by you as a midwife. Whereas with the more medical model of care, that's not standard, and that's not necessarily standard, even though it should be, and it's something that you need to advocate and ask for. You know, I feel like in my role also, like, so much of what I do, and I'm happy that I'm doing this because I want people to have the information, but it's so much of like, ask this question, ask if this is an option, discuss, not even ask, but like discuss this with your provider and say this is something that you would want. Because if you don't, then you're just going to get, you know, the standard, which is not necessarily in your best interest. It sounds like what you're saying is we're going to like try to like, I do this like hand motion, like support the process versus like, you know, get involved and like, okay, you know, like mess it up.
Exactly. Yeah. Because the more you start intervening, then things start happening.
It's so true.
Not always.
It's so true.
Right.
Okay.
Yeah. And then you have to really learn about it, read about it, you know, watch YouTube videos of whole birth or unmedicated birth, and you know what's crazy is that I have a friend who I worked with at NYU who just graduated midwifery school and was always like more into like hospital midwifery, and she started coming with us to home births because she wanted to get some experience and she wanted to see it. And I think we like rocked her world, to be honest. I'm not saying she's going to become a home birth midwife, but she was almost like, she's been a labor and delivery nurse and a midwife for a very long time. And she came to the home births and she's just like, I didn't know it could be like
That's
this.
awesome. I want to come.
Right.
Awesome.
Wow. I mean, we don't invite people to people's home births. She was coming as a professional to help.
You gotta you have to, it's like you have to see it or, you know, talk about it.
Almost.
Learn about
it. Yeah.
For sure.
Mm-hmm.
For sure. Okay, is there anything else you wanted to add? This has been really, really helpful and interesting.
I think that's it. If anybody has any other questions, they're welcome to put it in a comment box or send me a message privately. I'm happy to respond.
Definitely.
Thank you so much for giving me the opportunity to talk about this.
What's the best way for people to get in touch with you?
Probably just on Instagram, yeah.
Okay. See Colin. Amazing. Thank you so much for your time.
No problem. It was great.
And have a good rest of your night. We'll be in touch. Thanks so much.
Take care.
Bye.